Hello, everyone. My name is Vivian Chen, and I am a PhD student in the University of Hong Kong studying pharmacoepidemiology and pharmacoeconomics. So today I'm going to talk about Markov modeling, how it works, and how it can be applied to project disease burden and also conduct cost-effectiveness analysis. So first of all, what is health economic modeling? When it comes to talking about modeling, the term modeling always sounds technical and difficult, but actually modeling just means a simplified representation of the real world. So in health economics, we always try to model or predict the disease journey that patients will encounter based on the current patterns that we can observe at the present moment. Now, for example, in front of you, here is a cancer patient who receives standard care. So after diagnosis, he may suffer from a locally advanced disease stage for half a year, and then followed by a short recovery. But 3 months later, recurrence may happen, and this eventually leads to metastasis, which is a more advanced stage, and even death in the end. So every stage here naturally carries different costs and QALYs, because usually a more severe or more advanced stage, such as metastasis, patients actually tend to have a higher cost of care and lower quality of life per unit time. And now if we sum them up, we'll get the cumulative cost of care and QALYs specific to these patients in the future 15 months. And of course, not all the patients will exactly follow the same path. And the beauty of economic modeling is that we can project the cost and health benefit of patients under different scenarios. Now imagine that we have another cancer patient who get a new treatment. So possibly the health outcome of this patient could be much better because now he has received a new treatment, an effective and life-saving medication so that the patient recovers and lives longer than expected. But can we conclude right away that this new treatment is more cost-effective than the old scenario? Actually, the answer is no, because now, although the patient outcome seems better, we also need to pay for the cost of treatment, the cost of the side effects from the treatment, and if the patient lives longer now, but actually he still requires continuous treatment to maintain the effect, then the cumulative cost will go even higher. So that is why we can never conclude the economic value of a treatment easily until we list out all the possible costs and the health benefit in the two scenarios. So now you may also ask, well, these are only two disease journeys. It's also possible that they get a new treatment but still die, or the time spent in these disease stages will be shorter or longer due to random chances. So now what is the economic value of a new treatment in the general reality then? Well, these issues can actually be formally addressed by Markov modeling and probabilities this time. So Markov model is so far the most commonly used decision-analytic model in economic evaluation, or HTA, that is readily interpretable or understandable by many policymakers. And in the Markov model, there are several mutually exclusive health states that indicate the possible steps in a disease journey. Now, for example, here is a very simple Markov model that contains a healthy state, a sick state, and a dead state. So in any time, patients in the healthy state can move to the sick state or remain in the healthy state. And similarly, patients in the sick state can also move back to the healthy state again or remain in the sick state. So meanwhile, both healthy and sick patients can die with no arrows going back, which means that they are going to stay in the dead state forever once they enter it. So this is also called the absorbing state. Now, of course, many HTA that you see in the real world contain far more health states and far more complicated transitions, but theoretically, every Markov model should work similarly. Now, after setting the basic Markov model structure, patient will be allowed to move between the health states based on the transition probabilities per cycle. For example, if our cycle length is 1 year, it means that among the healthy patients, 15% of them will get sick and 20% of them will die in a year, while 65% of them will remain healthy in a year. So these probabilities are usually referenced from the current literature or computed using real-world data. And remember, the sum of the probabilities of leaving the current state to the other state must be always equal to 1. Now, finally, every health state is also associated with a cost and health outcome represented by a utility weight for their time spent in the state per cycle. For example, a sick state usually carries a higher cost and lower utility value than a healthy state per unit time. Okay, now with all the model inputs parameter ready, we can try to project the future burden. So now imagine that we have a hypothetical cohort of 1,000 patients, and they enter this 3-state model with cycle length of 1 year and time horizon of 10 years. So now what will be the total cost and QALYs after 10 cycles of simulation or after 10 years? So to calculate this, firstly, we can convert the transition probabilities into a matrix and also prepare a separate table to populate the figures. So now at cycle 0, we inject 1,000 patients into the model. And after 1 cycle, according to the matrix, there will be 1,000 people times 65% chance plus 0 times 35% chance plus 0 times 0% chance, which equals to 650 people staying in the healthy state after 1 cycle. And then we can do the similar calculation for the other 2 states. And of course, the subsequent cycles to populate their patient distribution at the end of each cycle. So now, according to the cost of each state per patient per cycle, we can also sum up the total cost per cycle by adding the cost among patients at each state. So in this case, we have 650 healthy people times $500 plus 150 sick patients times $2,500 and no cost for those in the dead state. So the cost of cycle 1 is equals to 700,000. And we'll do the similar thing for the remaining cycles. And now, finally, the concept of calculating QALYs is also very similar. So now the numbers on the left-hand side actually represent the number of life years in each state. For example, 650 people staying in the healthy state for 1 year of life, it's equivalent to 650 life years in this health state. So now we'll multiply the life years in each state by the utility weight specific to the state, and then sum up all of them together. Then we'll get 580 QALYs for cycle 1, and the logic is similar for the remaining cycles. Now, finally, we can sum up all the costs and QALYs in each cycle to obtain the cumulative values over 10 cycles. Okay, so now we have only simulated 1 scenario, but then HTA or cost effectiveness analysis typically involves the comparison of actually 2 or more alternative scenarios. So now we can actually repeat the entire process for the scenario of what if the patients receive a new innovative therapy. So this kind of scenario usually has a different set of transition probabilities, cost per state, or sometimes even a different a different set of utilities per state compared with the old scenario. So here, let's assume that in this scenario, the probabilities of sick patients becoming healthy again is increased to 60%, and the probability of dying, it's decreased to 25%, and they have only 15% chance to remain sick in the coming cycle. So although the medical care cost may drop due to a better healthcare outcome, it may still be outweighed by the cost of treatment, so that the overall cost in the 6 states will increase to $3,000. Okay, so now with a new set of input parameters, we obtain higher cumulative QALYs, but also a higher cumulative cost after repeating the simulation using the exactly same Markov model structure. Now, the big question is the new treatment cost effective? What does it mean? Because now it gives more QALYs than the standard care, but also comes with a higher cost. What do we do now? So now we can calculate a measure called the Incremental Cost-Effectiveness Ratio, or ICER, to get some hint. So the ICER is actually calculated by dividing the difference of cost by the difference of QALYs between the two strategies. And after the calculation, it shows that in order to introduce the new treatment, we need to spend $508 more to buy back one QALY. And now, what does it actually mean? What does the value imply? So in reality, different countries adopt different cost effectiveness threshold, or CET. Usually, the World Health Organization recommends the CET to be set at within 3 times of the country's GDP per capita. So in our example here, the new treatment is considered to be cost effective. But actually, sometimes we don't even have to calculate ICER if one scenario carries a lower cost and more QALYs, because it is obvious that it dominates the other choice and is cost effective by just eyeballing the results. So sometimes in an HTA or cost effectiveness analysis publication that you see, we can actually find that people are applying discounting to the projection as well. Now, this is a correct way to do so because the future cost and benefit will not be as valuable as the present moment. So they have to be discounted to the present values. And usually we'll take around 3% of reference from the projected inflation rate by local governments to set the discount rate. So after applying the discounting, sometimes we may get a different result or even a different conclusion as well. Now, as you may be aware, the model input parameters such as probabilities, cost, utilities, and even the demographic characteristics and model structure such as time horizon, cycle length, and discount rates, actually they are entirely selected by us, by the modelers. And more importantly, these are only point estimates that are reported by literature with sampling uncertainties as well. Therefore, we often see that the cost effectiveness studies that are published usually conduct sensitivity analysis to address the uncertainties surrounding the model outcomes. And the 2 most common analyses are deterministic and probabilistic sensitivity analyses, or they are commonly called the DSA or the PSA. So a DSA means that we vary each input parameters to its lower and upper ranges, such as its 95% confidence interval or 20% variation, and then we report the possible difference in the projections. And alternatively, a PSA means that we vary all the input parameters simultaneously according to their natural statistical distributions for a designated number of iterations. For example, 1,000 times or 10,000 times, and then report the possible range of the projections and also the percentage of them that supports a cost-effective conclusion. Now, of course, Markov model is only one type of economic modeling. It has its own advantages and also drawbacks. That's why we sometimes also see that people are using other types of modeling as well. And in recent years, some modelers even make use of AI to develop prediction models. And this will be covered by Dr. Jason Yang in another video. So I hope you enjoy this video and now have a better concept about Markov modeling. And finally, if you have any question, please feel free to email me for discussion as well. Thank you very much for your attention and see you.